he gets on. Okay, I think we'll get started. Thank you all for joining on a late afternoon. My name is Bill Smith. I'm director of the Life Sciences Initiative at the Pioneer Institute. My background is in government, both at the federal and state level, as well as industry, where I worked for more than 10 years. And I joined Pioneer a few years ago to launch the Life Sciences Initiative because the greater Boston area, and Cambridge especially, has the most important cluster of life sciences companies and institutions, foundations, medical schools, universities, probably in the whole world. So it's something that we're very interested in. I'm going to let my two colleagues from the Life Sciences Initiative, Robert Popovian and Gary Benoit, introduce themselves, and then we'll get started.
Thank you, Bill. Good afternoon, everyone. Robert Popovian. I'm Senior Visiting Health Policy Fellow at the Pioneer Institute. I have been with Pioneer for the last 12 months, but I've known Bill for a very long time, and we worked together at points at Pfizer. I was at Pfizer over 2 decades. Currently, I'm also have my own consulting firm. I'm affiliated with the Global Healthy Living Foundation, which is a patient organization. I'm the Chief Science Policy Officer, as well as at the Progressive Policy Institute and the Schaefer Institute. And I'm on the board of counselors for the University of Southern California School of Pharmacy, and look forward to this discussion. Gary?
Thanks, Robert. My name is Gary Benoit. I'm a research institute in the Life Science Initiative at Pioneer. I'm a recent graduate from Cornell University, BA in biology and sociology, and currently helping Bill and Robert out on a multitude of different projects at Pioneer. So excited to be here.
Thank you, Gary. And Gary was instrumental in developing this new tool we're going to show today. And the tool itself, you will see, maps out contract pharmacies for 340B institutions. And without some context, it's just a map with lots of pharmacies on it. So I want to start off by giving a little context, talking about the 340B program, and particularly talk about some of the conclusions we've reached about how the program has developed over the years. Okay, so what is the program? The program is a drug discount program for hospitals and clinics who qualify. And the background on the program was that in 1990, Congress passed a law called OBRA 90 that required drug manufacturers to provide Medicaid with the lowest price of any payer in the country. And this law created a problem because hospitals and clinics were already receiving on a voluntary basis some of the lowest prices from drug manufacturers in the country. And because of OBRA 90, those very, very low prices given to hospitals and clinics, particularly in low-income areas, were going to suddenly be forced to cascade into every state Medicaid program, all 50 states. So this created a problem. The hospitals felt like the drug manufacturers were going to withdraw these voluntary discounts. So they went to Congress, and in 1992, they passed the 340B program, which requires manufacturers to provide deep discounts to hospitals and clinics serving low-income patients. And these prices in the 340B program are exempt from that OBRA 90 best price rule. So some of these prices in the 340B program are among the lowest prices in the developed world. Lastly, let me mention, but on this third bullet, let me say that it's very clear from the legislative history of the statute that the clear purpose Congress had in enacting this law was twofold. One, to provide hospitals and clinics with a little additional revenue so they could serve through charity care, uncompensated care, or other means. They could serve low income or uninsured populations. And the second second goal was to provide discounts. So if an uninsured person came in and was treated at one of these 340B institutions, they could access a very low price for the drug if they had to pay cash. So that was the twofold purpose of the program. And let me just mention, because this helps explain some of the growth in the program, facilities or institutions become eligible for 340B discounts if 11.75% of their patients are Medicaid. Now, Medicaid, of course, means that the patients are insured, but Congress felt like a double-digit percentage of treating Medicaid patients was a proxy for serving low-income populations. So they put that is now the eligibility requirement for the 340B program. And let me talk a little bit about in the next slide about how the incentive structure of the program is. Congress thought this would be a simple matter. We'll just give drug discounts to these institutions. What they didn't necessarily see in the future is that the institutional bias of this program is towards covering insured patients. And let me demonstrate why. Say a Medicare patient wanders into a 340B hospital and they are diagnosed with cancer and they need a cancer drug. The hospital under the 340B program has purchased an oncology drug for $25,000. And that drug has a list price of $100,000, a 75% discount, which is not unusual in the 340B program. So the patient receives that drug and the hospital bills Medicare at 106% of average sales price, which is the Medicare Part B reimbursement rate. And let's say that rate is $95,000 for that $25,000 drug. The hospital's profit on that drug, because they were able to purchase this at 340B prices, is $70,000 on one prescription. So there's a great incentive to get Medicare patients in. There also is an incentive to get commercial patients with good commercial insurance in. So a commercially insured patient comes into the hospital. Again, the hospital buys the oncology drug at $25,000. They dispense it to a commercially insured patient. The hospital bills the health plan at, say, 75% of the list price. That's the negotiated rate that the health plan has negotiated with the drug manufacturer. In this case, because the hospital was able to purchase the drug at a $25,000 price under 340B, the hospital's profit for that commercially insured prescription, one prescription, is $50,000. So you see the enormous bias in favor of getting patients with insurance into a 340B institution and how lucrative that can be for these institutions. In the case of an uninsured patient, not so lucrative. You know, an uninsured patient comes in, the hospital purchased the oncology drug at a discounted price of $25,000. They dispense it to the uninsured patient. The patient gets a bill for $25,000. Hopefully the discount is passed on to the patient. Hopefully the patient has a manufacturer assistance coupon or some kind of copay assistance. But nonetheless, in this case, the hospital's profit on the uninsured patient is zero. They make no money off this particular patient. So many of the incentives in this program are biased towards covering commercially insured patients. And let's go to the next slide. And what we call this is arbitrage. The hospitals and clinics are able to buy the drugs at a low price and charge a higher price. That's classic arbitrage, Wall Street or anywhere else. One economist estimated that the spread between what the hospitals bought the drugs for and what they were reimbursed for in 2019 was $40 billion. So that's $40 billion in profits. They're technically not profits because these are nonprofits, but nonetheless, it's $40 billion in revenue through the 340B program. And what the program has instigated, again, because of the incentive structure that I just talked about, is a massive takeovers of community-based physician practices, particularly in high-income areas. So again, the program has an incentive to get patients in the door who have good insurance. So why not open satellite offices in wealthy suburbs? If you're an urban hospital and you've qualified for 340B, open up a satellite office in a wealthy suburb, get some of those patients to come in and buy up physician practices, particularly physician practices that dispense high-cost drugs. Oncology, rheumatology, and other specialties are particular targets of hospital takeovers because of 340B. And of course, the program has seen uncontrolled growth. When you have these kind of incentives and this kind of revenue at stake, the program has taken off. In 2021, there were $43.9 billion in drugs purchased by hospitals and clinics under 340B, but that's at discounted prices. If those drugs were purchased at list prices, it would have been $93 billion in sales. So by 2026, this will be the largest federal drug program, eclipsing even Medicare Part B and Part D. And a more recent phenomenon since 2012 is many for-profit entities have gotten in the game. For-profit pharmacy chains, in particular, CVS, Walgreens, Walmart, have gotten in the game, as well as PBMs that own many specialty pharmacies that dispense these drugs. And the margins in the 340B program are very, very generous for pharmacies. So they have flocked to these. The number 32,000 pharmacies I list in this presentation, but you're going to see the updated number is closer to 37,000. That's 32,000 is last year's number. So the program is just experiencing exponential growth and profits for for-profit entities. And this is ironically a program that's supposed to serve the low income and uninsured. The number of covered entities has grown enormously. There are now 10,000 covered entities or more. They started out with a very small number in the 1990s. And in the first few years, there were only about 550 hospitals that qualified. And part of this growth is due to the fact that Medicaid has exploded. Due to the ACA and other Medicaid expansions, the program has grown by 30 or 40 million patients. And as I indicated on an earlier slide, you become eligible as an institution for the 340B program when 11.75% of your patients are Medicaid. And now that there are 80 million Medicaid patients, many more institutions are qualifying. So that part of the growth is explained by Medicaid growth. Now, we can talk about all of these problems in the program and the arbitrage and all the revenue they're making and the for-profit institutions that are making revenue. The thing that strikes me most about this program and the thing that's most disconcerting about this program is as it's grown enormously, there is pretty good data to suggest that as hospitals have gotten more and more revenue, clinics have gotten more and more revenue, it is harder and harder for an uninsured or low-income patient to find charity care. Charity care has been scaled back by hospitals and clinics. At the same time, they're getting unprecedented growth in revenue from the 340B program. In fact, the American Hospital Association itself reported in 2016 that uncompensated care in their hospitals had fallen to 25-year lows in both 2015 and 2016. And these were years with huge growth in the 340B program. So the whole purpose of this program has been distorted, in my view. It started with the best of intentions to serve very vulnerable populations, and now it's become a revenue machine that's serving wealthier populations, insured populations, and is bringing in lots of revenue at the same time that charity care by hospitals has been declining. And with that, I'm going to turn it over to Robert to show you the tool.
Thank you, Bill. And for our audience, if you have questions, please put it in the Q&A format in the Zoom. And Gary is going to be monitoring that. And at the end, we're going to have plenty of time to answer all your questions. So please don't be shy, don't hesitate. Please ask any questions that you may have. Just put it in the Q&A within the Zoom, and we will be able to address those. So why do we do this? Why do we start this project of Contract Pharmacy 340B? Bill and I wanted to see and provide some transparency on where these institutions, these pharmacies are located. Since passage of ACA, as he mentioned, the number of institutions that are eligible for 340B discounts, these covered entities have increased. And then when HRSA removed the cap on number of contract pharmacies, that number has also exploded, and we will show you the data that we can support. And all of this data that we have in this tool that is publicly going to be available on the Pioneer website is from HRSA. This is not some proprietary data from Pioneer or any other institution. This is all available for HRSA. What we did is took the data in, analyzed it, and what we're trying to do is, the purpose of the project is to do the micro assessment of geolocation of these contract pharmacies that are working for these eligible entities. And really, the impetus of this tool was a JAMA article that came out last year. Bill and I were very interested. We read through it, and one of the things that this article did is look at it more from a global level and a macro level of where these pharmacies are located. And their conclusion was that these pharmacies are more in the affluent neighborhoods based on zip code data, rather than the poor neighborhoods that supposedly they should be serving. So what we wanted to do is bring it down to a much more micro level and allow our audiences, anyone who's interested, policymakers, advocacy groups, provider organizations, anybody who has an interest in this, academics, to take a look at it through this tool and see where these locations of these pharmacies are. So when you go to the Pioneer website, this is what you will see. It's the landing page. It will look like this. We have a couple of paragraphs to explain what the tool is, what the 340B program is. It's very brief. It's really to get people interested. Then what you can do is then start exploring the tool. It has several tabs. The first tab is really looking at contract pharmacies within states. So I picked the state of California because that's where I grew up after we immigrated from United States. And in the state of California, you can click on all entities or covered entities, and you could see all of the covered entities that are in the state of California that are eligible for 340B. And you could see it categorized based on entity type. So if they're a disproportionate share hospital, for example, you can see it's color-coded. Then you can go, and on the right side, you will see that I clicked on the hospitals portion, which is for California for hospital, and you see that the #1 hospital system in California that has the most number of contract pharmacies is the University of California Davis Medical Center. And in University of California Davis Medical Center has 262 contract pharmacies affiliated with it currently. And this is based on active contracts as of 2023. So the most recent data. So you can basically take a look at the covered entity, look at the number of contract pharmacies they're affiliated with. The next tab is really a macro level, national level look at the growth of the 340B program, both from a covered entity perspective, which is the first graph. You see that in 1992, there were 252 covered entities, and by this last year, there were 10,346. Primarily, you see the explosion happened during the passage of the ACA as more patients became eligible for Medicaid, as Bill mentioned, and also the criteria basically was loosened up. The second and the third graph are with regards to contract pharmacies again. So the second one is a cumulative number. This is all of the contract pharmacies over time that have participated in the 340B program. They've become eligible to be contract pharmacies for the 340B program. So in 2001, we had 16 pharmacies, and by 2022, there are 53,000 accumulative numbers. So in the United States, 53,000 pharmacies at some point have participated in the 340B program. The final one is really the most important one, in my opinion, with regards to contract pharmacies, because it demonstrates the growth of the contract pharmacies that have active contracts as of today. So as of today, in 2023, there's 37,000 pharmacies in the United States that have active contracts for become 340B eligible pharmacies that have active contracts. That means they have active contracts with covered entities. Now, why is this important? Because what Bill alluded to, in the United States, there's between 60 and 80,000, depending on the number that you fetch, depending on how they count it, of pharmacies available, retail pharmacies are available. So what you will see is that more than half, if not significantly more than half, of pharmacies are eligible for 340B pricing in the United States. This is, again, not surprising because, you know, other folks such as Adam Fine have commented how certain chain pharmacies currently, almost 90% of those chain pharmacies are eligible for 340B pricing. They become eligible for 340B pricing. So the explosion happened really when the HRSA took off the cap, and you saw a growth. And currently, over half, if not significantly more than half, of pharmacies in the United States are eligible as 340B for 340B pricing and have active contracts with covered entities in the United States. This, at the face of it, doesn't make sense. You know, we don't have 50% of the US population is not indigent, they're not poor, they're not Medicaid eligible. So all of these numbers show that the explosion has happened because there's an entity out there that is trying to profiteer. And as Bill mentioned, it's very lucrative both for the covered entities and pharmacies to participate in this program. The next tab you can look at, again, I looked at the state of California. What you see is that the state of California, there's 1,606 contract pharmacies, and you see where the locations are. Majority are in the state of California, but then they're sprinkled all over the states. And then you can click on, if you look at the right side, at the institution. So for example, you can click on University of California in Irvine, which is the #1 institution covered entity in California, of hospital covered entity in California that has contract pharmacies. And you see out of the 262, how many are in California and how many of them are outside the state, which becomes the big question of why are there so many contract pharmacies that are supposed to be serving patients of UC Davis outside the state of California. There are pharmacies, they have contract pharmacies in Texas, in Florida, in Maine, and it just doesn't make sense of why they are, because if these patients are indigent patients, poor patients, why are there so many contract pharmacies outside the state lines? And yes, some of them may be mail order pharmacies, but the question needs to be asked, aren't there enough mail order pharmacies within the state of California that these entities have to go and contract out with pharmacies outside the state? Remember, this is serving poor population, indigent population, who's not going to travel back and forth. These are not affluent people that live part of the year at one state and then another part of the year another state. And the argument is that why are there's so many contract pharmacies outside the state lines? The next tab really looks at zip code level data. So what we've done, again, in the state of California, you can put a zip code, for example, a zip code 90004, and you can find out how many contract pharmacies are in that zip code. This is going to be super important because I will show you data later in a couple of slides that demonstrates how these contract pharmacies are really located in affluent neighborhoods in the states rather than the more poorer zip codes that these patients sort of exist. And this is, again, a confirmation of what that JAMA article investigated, and also the reports that you've seen, whether it's in the New York Times, of how these covered entities start up in getting eligibility in poor neighborhoods, and then they go into more affluent neighborhoods, expand care there, while taking away care in the poorer neighborhoods. And you will see this in the next few slides. So what you can do is go to the state, put on the zip code, and you can see if there's a contract pharmacy and how many contract pharmacies are in that zip code that have an active contract with a covered entity. This is just the state ranking. This is the last tab. So what you see is that in the first one, California has the most covered entities overall, and it also has the most eligible or active contract pharmacies currently. In the right side, what you can see is that when you go down to the hospital level, it becomes New York in both regards to covered entities and contract pharmacies. So it's just a ranking of the states to see where your state stands. It's not a surprise that New York and California are 1 and 2 or 2 and 1. And the reason being is that they're most populous states. And then it's Texas in most of the cases as number 2 and Florida. So here's the most important thing. Where are these contract pharmacies located? And if truly this program is meant to serve the poor and the indigent, why are these so many contract pharmacies in affluent neighborhoods and not in poor neighborhoods? Just like the JAMA article, but this is more of a micro level analysis. So when you look at nationally, the top 10 poorest zip codes in the United States and the top 10 wealthiest zip codes in the United States, based on the HRSA data that we have and that anybody can go ahead and look at, there's 6 contract pharmacies in the affluent neighborhoods, in the wealthiest neighborhoods, and 0 in the top 10 poorest neighborhoods. Okay, so that's a national level. What about state level? So we picked the state of California, Virginia, Massachusetts, and Louisiana, and no other reason that I told you my background in California. I live in Virginia now, Pioneers is based in Massachusetts, and we wanted to pick a poorer state in the union to see how it reacts. And the same pattern follows in every state. So we looked at the top 5 wealthiest versus the top 5 poorest zip codes in these states. And what you see is exactly the same pattern. There are more contract pharmacies in the wealthiest zip codes than there are in the poorest zip codes. In California, it's 7-1. In Virginia, it's 5-2. In Massachusetts, 13-5. And in Louisiana, is 27-11. So this tool allows anyone to look at not only whether or not their zip code, how many contract pharmacies there are, but also do a comparison of wealthy zip codes versus poorer zip codes, and truly see where these contract pharmacies are located. As I said, the whole purpose of this program is to serve the poor, indigent, and uninsured. And what we're seeing is that if that is true, and the eligibility criteria is that is the eligibility criteria, and we've seen the growth in the covered entities and the contract pharmacies, these contract pharmacies are not really serving those neighborhoods, or they don't exist in those neighborhoods. Now, having said all of this, so what is the next iteration of the tool that we would like to get involved in? Is besides doing the zip code mapping, the micro level mapping on the zip code level, we want to do geographic mapping of contract pharmacies based on federal legislative districts. Zip codes don't always align with legislative districts on the congressional level. We want to do that. The second thing we want to do is identify pharmacies per zip code. So we know how many pharmacies are in that zip code. But who are they? Are they independents? Are they chains? So we are going to try to identify each one. So when you go on this tool and put on the zip code and find the number of contract pharmacies, when you click on it, you will then see exactly who those pharmacies are. So you can see if it's a mail order pharmacy, or if it's a privately owned pharmacy, or it's a chain drugstore. It's we're going to try to do that next. And finally, what we want to do, and Bill, I know, has a lot of commentary on this because this is written extensively on this topic, is the inclusion of percentage of charity care per covered entity in the tool. So when you go and look at a covered entity such as UC Davis, you can then see how much charity care are they providing according to CMS data that they're supposed to provide to CMS. Now, we all know there's no uniform criteria what charity care is, and that's one of the things we want to talk about legislative fixes that Bill can talk about with regards to transparency. But at the end of the day, there is data available through CMS that we want to capture. And then for each covered entity, next to the covered entity, put percentage of charity care that covered entity is providing. And that's one of the things that we want to do. But I want to have Bill say a few words about that because he's written quite a bit extensively on this topic, and also specifically talk about the case study that he did in Massachusetts. Bill?
Thanks, Robert. And I think Gary should read the question. We have one question in the queue, and my answer will address the charity quick care question that Robert raised because of this question.
Yeah, so the question we have in the Q&A right now is that while the nonprofits are making high margin dollars on these drugs, if you look at their recent financial performance since COVID hospital aid ended, they're losing huge sums of money due to staffing and other issues. So the question is, where would they be without these revenues? Possibly bankrupt?
Yeah, so my answer to this question is we are very well aware of the financial condition of hospitals, not just because of COVID, but because of low Medicaid reimbursements and other financial challenges. Massachusetts has a huge cluster of hospitals. I'm very well aware of their financial condition, their challenges, their labor challenges, their cost challenges, and their reimbursement challenges. And that for that reason, Pioneer has not recommended, and we are not recommending, any massive cuts in this program. We're not recommending scaling this program back. We are not recommending cuts in revenue for hospitals for this program. What we're recommending as a first step is just some transparency. We would like to know, and this information is not disclosed now, how much revenue each hospital is taking in from the 340B program. Just give us a number. Tell us how much revenue this program produces for you. And at the same time, we'd like to know, under a uniform definition of charity care, how much charity care you are providing to the local community, because the goal of this program was to give revenue to hospitals so they could provide charity care. And right now, while hospitals do file with CMS reports annually where they lay out their charity care, the definitions that different hospitals use are different. So if a middle income patient comes in and doesn't pay their deductible for their MRI, is that charity care? Some hospitals say yes, some hospitals say no. We would like Congress to step in and say, here's what charity care is, so that we know we're talking about apples and apples. But again, any reform of this program should start with some transparency. And once we know how much revenue a hospital is making and how much charity care that they're getting, we can know based on their balance sheet and their financial condition whether they're doing the right thing or whether they're doing the wrong thing. So we'd recommend just starting with a little transparency and not scaling back these programs. I am very well aware of hospitals that are in very acute financial conditions. Their reimbursements are low. COVID devastated them. We don't want to make it worse by arbitrarily cutting this program, but we do want to know what they're doing with the money from this program. And we don't know that right now.
And just to add to what Bill said, the same thing applies to pharmacies, right? So we're going to ask the pharmacies also provide charity care that they're providing, because they're become eligible for this 340B pricing. Technically, what they're saying is that they're serving these patients who are uninsured, underinsured, or Medicaid patients. And, you know, at some point, I believe that there are plenty of pharmacies, both independents and retail chain drugstores, that are doing the right thing. They're serving patients in zip codes that they're pharmacy deserts, and they're staying in and they're struggling financially, and they need to be applauded and supported. And we want to maintain that level of service and commitment to those pharmacies in those zip codes. But the question becomes, why are you in Beverly Hills and not in South LA? And that's the question that policymakers need to ask, is that if you're truly serving the community of South Los Angeles, which is one of the most poorest neighborhoods, or East LA, then why aren't you in those zip codes? And instead you're in Beverly Hills, California, or Westwood, or in Palo Alto, for example, which are some of the wealthiest zip codes in the United States. So those are the questions that we need to ask. And why are there so many of these pharmacies out of the state lines? Why are there so many contract pharmacies outside the state of California that are servicing patients in University of California, Davis, or UCLA, or any of the other institutions in the state of California, for example? And the same thing applies for all the other institutions. Those are the questions that policymakers need to ask. And those are the way we get there is through what Bill said, some transparency of why are these things happening.
Yeah, what we discovered in our research in Massachusetts, for example, is that there are some hospitals, and I'll call them out because they're doing the right thing, Boston Medical Center, as well as a couple of Cambridge hospitals, Cambridge and Everett, that are giving charity care at a level of between 7 and 13% of their patient revenue. So 7 to 13% of their patient revenue turns around and goes to charity care. We're seeing other hospitals, which will go unnamed, that are very wealthy, that have endowments where they're giving 1% of less of their patient revenue in charity care. So we just want to find out what's going on and how much money these hospitals are making and where the money is going. That's the simple place to start in reforming this program.
I want to see if there are any other questions. Gary, are there any questions in the Q&A?
We don't have any questions right now, but yeah, please feel free to plug anything in as we reach the end of our discussion.
Yeah, if you go to the next slide, Robert, you can see my contact information. Feel free to email me or drop me a text or whatever. And if you have questions that come up later, if you play around on the website is live on the pioneerinstitute.org website. You can go on it and play around with it and put in zip codes and see in your area what the contract pharmacy profile looks like. So unless there are more questions that chop up in the queue, I think we'll give everybody some of their time back this afternoon. And thank you all for joining. And again, we're wide open to questions at a later time. If you want to go ahead and email me at wsmith@pioneerinstitute.org.
Bill, there's one more.
Oh, wait, one more just popped in.
It's the
Yeah.
question.
Contact information is there.
Exactly. All right,
Okay.
thank you, everyone.
Thank you all.
Take care. Bye-bye.